Now what I would like to do is introduce Dr. Jennifer Malin and Ms. Shelley Fuld Nasso. If you could come up to the podium. And they will present today's final spotlight session on the role of payment reforms in supporting innovative cancer care. Dr. Malin is the Medical Director for Oncology for Care Management at WellPoint, Inc. She's board certified in internal medicine and medical oncology and is an Associate Professor of Medicine at the UCLA David Geffen School of Medicine. She's widely recognized for her research on the quality of cancer care and has served on ASCO's Quality of Care Committee and the National Quality Forum's Cancer Endorsement Maintenance Project Steering Committee. Our second speaker, who will continue right after her, is Ms. Shelley Fuld Nasso. She's Chief Executive Officer of the National Coalition for Cancer Survivorship, where she focuses on advancing policy change that can directly benefit patients. Prior to joining NCCS, she served in leadership roles at Susan G. Komen. Earlier this year, she also served on the Turning the Tide Against Cancer expert working group that informed the publication of the Turning the Tide issue brief that we keep mentioning today. So please join me in welcoming first Dr. Malin, who will open the session, then followed by Shelley Fuld Nasso, and then we will have time for a couple of questions, okay?
Well, thank you, and I'm glad to see some people manage to hold out for the very last session here. We'll try to keep you awake. So I'm going to kind of bring back what I think has been in the elephant in the room for some of today, where we've talked about innovation, but then we've been talking about concerns about costs maybe being a barrier to innovation. And so I just wanted to highlight this from the standpoint of why this is a reality. So the median household income last year was $52,000. The cost of a family's health care is $22,000 last year. If you look at the employer's share of premium, the employee's share of their premium, and their out-of-pocket costs. And in just a couple of years, given the relative growth rate of healthcare costs compared with income, it's going to exceed 50% of people's income. So now this, we often talk about this as if this is a bad thing, and I'm reminded that a couple months ago there was an article in the New York Times about how for most people around the world, 50% of their income goes to food. So and in the United States, we spend less than 10% of our income on food. So this largely reflects our wealth and our ability to spend more of our resources on health. So that's a good thing. I think what is raised concern is that at the current growth rate, it's going to start to take away from other things that we might want to be, that we find of value, like education and natural resources and other things that we value. There was some discussion earlier about why the focus on drug costs and what's the big deal. And there certainly is a lot of waste in the healthcare system. I think by many measures, 30% of what we spend on healthcare is wasted, which means it's not helping anyone, it's not benefiting anyone, it's not patient-centered, it's just waste. But if we look at cancer care, and this is the spending from WellPoint's affiliated health plans perspective, this is spending on cancer care for patients in active treatment, regardless of whether they're getting surgery or chemotherapy or radiation or any combination thereof. We see that a quarter of the cost goes to chemotherapy and supportive care drugs, and that part of the cost is rising the most rapidly. Specialty pharmacy costs are increasing at over 25% per year for oncology specialty drugs. So this is a big issue, and when you look at when I look at this pie, the part I think of as the patient-centered care is the E&M codes, that 3% up there. And so if you think of this pie probably not getting much bigger, because as a country, we probably can't afford to spend much more than 50% of our income on healthcare. If we're going to keep spending more and more on drugs and fancy radiation technology and things like that, we're going to have less and less to spend on patient-centered care. And so here, just as an exercise, are 6 regimens for non-small cell lung cancer. They're all considered standard best choices by NCCN. They're for patients who don't have the EGFR ALK mutations, which would make them a candidate for one of the new targeted therapies. So these are most of the lung cancer patients. Probably 80% of lung cancer patients who are diagnosed with metastatic disease, the doctor is going to be choosing between one of these treatments. And you can see that the survival across these treatments, if you look at the numeric survival reported in the study, ranges from about 10.4 months to 13.4 months. Although if you look in those studies that reported the confidence interval, which means if you repeated this study over and over again, what would be the kind of range of survival you would see? For the most part, these are all overlapping. If you look at the side effect profiles, they're pretty similar. Some of them have a little more neuropathy. Some of them have a little bit more of grade 3 or 4 fatigue. Fatigue may not sound like very much, but grade 3 or 4 fatigue means like you can't get up out of bed. So very debilitating fatigue. And then you look at incidence of hospitalizations. We've been talking about the studies don't capture quality of life. They also don't just capture sort of the real impact of the side effects on people, and that's an issue. Very few report the hospitalization rates, and so it's very hard to even know how to choose one treatment or another for an elderly lung cancer patient. And then finally, the last column is deaths on treatment, and you can see that this actually varies somewhat across these studies as well. Some of it's due to differences in patient populations, but you can see treatment E, 4% of patients died on treatment, thought to be due to treatment, relative to less than 1% for treatment A. Now, most oncologists, I would say, we tend to focus on that first column of estimated survival. And we sort of compared, in trials, 2 different arms, and we picked the one that we think has the best estimated survival. But I would argue that to patients, and if we really had tools to share this information with our patients, things like the likelihood of dying during the next 3 months while I'm on treatment might be just as important, if not more important, than whether I had a chance of living an extra 2 weeks longer at the back end if I survived that time. But here I think is the even more startling difference. Overall, these treatments don't differ by very much, which is why NCCN and the other guidelines basically treat them as equivalent. They're all good choices for first-line therapy for lung cancer. Yet the variation in cost goes from $450 for 4 cycles to $65,000 for 4 cycles. So, the question is this really innovation? Have we made that much stride in treating lung cancer? Is there really that much difference here that warrants essentially spending $63,500 more to treat someone for the outcome that we're getting? And so is our current paradigm really driving real innovation that's really making a difference in patients' lives? And what would be meaningful outcomes to patients? And I think we've heard a couple of really compelling talks today and discussion about the things that matter to patients that aren't even addressed. But this is from a study that was published in the New England Journal of Medicine several years ago by Jane Weeks, an incredible oncologist and researcher who actually unfortunately died of breast cancer a little over a year ago. But in this study, and this was from a national survey of patients with metastatic lung and colorectal cancer, and these patients were asked, how likely is it that the treatment is going to cure you of your cancer? And 70% of the patients with lung cancer said that it was either a little likely, somewhat likely, or very likely that they would be cured. And over half of the patients with colorectal cancer. Now, there's lots of debate about, well, did they just not understand their prognosis? Did the doctor forget to tell them? But I just want to point to this in a different context. This is their expectation. This is their hope of treatment. So these people are not putting up with treatment. Forget about the cost for a second. They're not putting up with the side effects of treatment because they believe it's going to help them live a month or two longer. They're putting up with the side effects of treatment and the burden of treatment because they believe and hope it's going to cure them. And so I think that's really important to think about when we think about what's the value of all this to patients and what they're hoping for. So the Institute of Medicine really focused on this last year with charting a new course for cancer care. Am I already out of time? Looks like it, sorry. I will whip through here. And so one of the main things that the Institute of Medicine highlighted was the need to realign our reimbursement models so that we reward quality and value in the way we provide care to patients. And so building off of that, WellPoint and its affiliated Anthem Health Plans has been developing and implementing a new cancer care quality program where we have a program for rewarding high quality care. We use a system that's been alluded to a couple of different comments of cancer treatment pathways. So we have cancer treatment pathways, and if that basically are the subset of the guideline recommended regimens that are the most effective, have the best side effect profiles, and when there's multiple options available that are at different costs, focuses on those that are lower cost. And if physicians treat our members on those pathways, they're then eligible for additional reimbursement to pay for that treatment planning and care coordination and the time with the patient that is not being covered by the profit on the drugs because they're using more cost-effective therapy. The platform that this system is built on is a web-based platform that provides decision support that also allows us to automate the process of prior authorization for those drugs that require prior authorization, so that the practices that are using it are telling us that so far it's also led to a decreased administrative burden for them as well. So the additional payment, as I mentioned, is for care coordination and treatment planning. It's $350 a month for patients on active treatment. And the goal is to use this to help keep practices whole and have them come out a little bit ahead so that they can provide patient-centered care while delivering value-conscious care at the same time. I should emphasize that the pathways are optional, so a physician can always choose a regimen that's not on pathway if they believe that the patient would benefit from a different treatment. The treatment still gets reimbursed just as it would today. They just don't get the additional $350. And so just in conclusion, I want to emphasize that payment reforms are essential to realign reimbursement so that we reward quality, value, and that we start to foster real innovation. Thank you.
So it's not advisable to be the last speaker on a long day of presentations when people are tired and want to get to the reception. But and also I feel like much of what I want to say has been said today. So I'm going to skip my slides and just reiterate a few points that I think are really key. You know, we've talked about the need for truth-telling, and I think there's a lot of truth-telling that needs to happen. You know, there's finger-pointing between pharma and insurance companies. There's struggles between hospitals and community-based care, and the patients are in the middle, and the patients get lost in all of that. And I think that we do need the truth-telling because I don't think patients really understand all these forces that are happening and that are influencing the care that they're receiving. I know that there's been some patients and industry folks who who don't like the idea of pathways and who have concerns about some of the approaches. But the truth is that we have a lot of bad incentives built into our system that affect the way patients get their care. And so there's not that transparency and there's not that truth-telling, and patients don't see that. So, I think it's great that we are talking about ways to help inform. We've talked a lot today about communication and to help inform that doctor-patient communication. And we can have better data from real-world evidence that shows how, how when you move a drug from the clinical trials to the real-world setting, how it works for patients. And we can have better tools to help talk to patients about value and efficacy and side effects and what's right for them. And you can have better tools to talk about patient-reported outcomes. But the fact is you have to be able to have those conversations with patients and that's where we see in the payment reform and the delivery reform that needs to happen is the better conversations with patients about those things. And the payment reform would be to reward physicians for having those conversations, because we heard that in 15 minutes, if that's all you're allotted, you can't have those conversations. So all the tools and all the data in the world will not help inform that discussion with that patient if there's not reimbursement for the time it takes to do that and to have a thorough and complete care planning process that really takes into account what's right for that patient. And, I had the opportunity yesterday to hear Dr. Atul Gawande talk about his new book that's come out this week called Being Mortal, Medicine and What Matters in the End. And he really focuses a lot on end-of-life care. But I think that the lessons he talks about are really applicable to all of cancer treatment, not just at the end of life. He said one of the lessons that he said was, in medicine and society, we fail to recognize that people have priorities that they need us to serve besides just living longer. And the best way to learn those priorities is to ask about them. And he talks about questions that need, just very simple questions that we need to be asking patients to to facilitate those conversations. What do you understand about your disease? What are your biggest fears and concerns? What goals are most important to you? And what trade-offs are you willing to make? And so if we don't reimburse for the time it takes to ask those questions and have those conversations, and then I think also on the other side of that, we have to also prepare patients to be able to participate in those conversations and to be able to really think through and talk about what is important to them and share that with their physician. Sometimes they're afraid to talk about those things, but if they don't talk about that this is what's important to me, then the treatment choice might be something that doesn't match what their goals and priorities are. And so that's what we see as really important in payment reform and delivery reform to help improve patient care. And we can create tools that help support that. But if we don't have those conversations, if those conversations are rushed and if they're not effective, and if patients walk out if they're thinking that they're still going to be cured because there wasn't sufficient truth-telling or truth-hearing, and I'm not saying that it's not said, but if they don't hear it, then it wasn't said well enough, because they need to be able to walk out of there understanding that, because it informs the decision that they're going to make. So I think that if we can, there are a lot of different efforts out there to reform the way we pay for cancer care, and what we focus on in making sure any of those efforts pays adequately for that time and discussion with the patient and planning, so that the patient really understands and has an active role in creating that care plan and treatment plan for them. Thanks.
Great, thank you, Shelley and Jennifer. We can take one or two questions from the audience, if there are any. No questions. Yes, one, please.
So this is something I was thinking about today. We had a lot of conversation about doctor-patient relationship, but is there any sort of infrastructure for patient-to-patient support and relationship? And so that patients who are going through the same thing can talk to each other about it as they kind of go through?
So, I think that the internet definitely facilitates a lot of that, and especially in really rare diseases, patients are finding ways to connect with each other. I've talked to some patients who are part of a support group for a rare kind of leukemia that they'd never met in person, but they considered themselves very close friends because they'd really helped each other through these treatment decisions that they had to make and through clinical trials that they participated in. And then I know that many groups here, Cancer Care, Leukemia Lymphoma Society, American Cancer Society, have different ways of really helping connect patients with other patients that have the same diagnosis. I think patients really want to understand, talk to people who have the similar diagnosis to them and are in the same situation.
One more question?
It's just a response to the previous question, but I'm Bo Aldeget from the Prevent Cancer Foundation, and there's an organization called Stupid Cancer, which focuses their audience as young adults with cancer, And we have agreed to help fund an app they're developing for young adults with cancer, because young adults with cancer do not like to go to in-person support groups. They like to use the internet. They like to use technology. And so we're helping to support that. So that's yet another resource. So they are out there.
Thanks very much.